Okay, so we're doing corneal abrasions. Symptoms is a sharp pain, photophobia, foreign body sensation, tearing discomfort with blinking, history of scratching or hitting the eye. Sign: it's critical that when you examine the cornea, you can see epithelial defect that stained with fluorescent, absence of underlying corneal opacifications, presence of which indicate infections or inflammations. Workup: slit lamp examination. Use fluorescein dye. Measure the size, example height and width, of the abrasion and diagram its location. Evaluate for anterior chamber reactions, infiltrate, underlying corneal opacifications, corneal lacerations, and penetrating trauma. Evert the eyelids to ensure that no foreign body is present, especially in the presence of vertical and linear abrasions. Treatment: 1. Antibiotic. For non-contact lens wearer, antibiotic ointment, for example, erythromycin, bacitracin, or antibiotic drops, or fluoroquinolone (QID). Abrasions secondary to fingernails or vegetable matter should be covered with fluoroquinolone drops, for example, ciprofloxacin or moxifloxacin, or ointment, ciprofloxacin at least QID. For contact lens wearer, must have anti-pseudomonal coverage, may use antibiotic ointment or antibiotic drop at least QID. Two, cycloplegic agents, for example, cyclopentolate, 1% or 2 to 2% BID or TID, for traumatic iritis, which may develop 24 to 72 hours after trauma. Avoid steroid use for iritis with epithelial defects because it may retard epithelial healing and increase the risk of infections. Avoid use of long-acting cycloplegic for small abrasions to allow for faster visual recovery. Patching is rarely necessary. Consider topical non-steroidal anti-inflammatory drugs, NSAID drops, ketorolac, QID for 3 days for pain control. Avoid in patients with other ocular surface disease and in post-operative patients. The bright loose or hanging epithelium because it may inhibiting healing. A cotton-tipped applicator soaked in topical anesthetic. Example, proparacaine, or a sterile jugular forceps used with caution may be utilized. No contact lens wear. Some clinicians use bandage contact lens for therapy. We rarely do unless the size of the abrasion and the discomfort warrants it and there is poor healing in the absence of infections. If a bandage contact lens is used, patients should be used prophylactic topical antibiotic, for example, fluoroquinolone, and should be followed up daily for evaluation and contact lens replacement. Follow up for non-contact lens wearer. If patch or given bandage contact lens, the patient should return in 24 hours for re-evaluations. Central or large corneal abrasions, return the next day to determine if the epithelial defect is improving. If the abrasion is healing, may see 2 to 3 days. Instruct the patient to return sooner if symptoms worsen. Revisit every 3 to 5 days until healed. Peripheral or small abrasion, return 2 to 5 days later. Instruct the patients to return sooner if symptoms worsen. Revisit every 3 to 5 days until healed. Contact lens wearer, close follow-up until the epithelial defect resolves, and then treat with topical fluoroquinolone or tropomyosin drop for additional 1 or 2 days. The patient may resume contact lens wear after the eye feels normal for a week after cessation of a proper course of medications. A new contact lens should be instituted at that time.